Hello again. This is Earl Silverman, editor-in-chief of the Journal of Rheumatology. I want to highlight a paper of particular interest to the readership that will be published in our May 2021 edition of the journal. Article I picked this month for my interviews entitled "The Risk of Cardiovascular Events Associated with Disease-Modifying Antirheumatic Drugs in Rheumatoid Arthritis," and is by Ozen, Pedro, and Michaud, and from the University of Nebraska Medical Center, Omaha, Nebraska, and forward the National Data Bank for Rheumatic Diseases in Wichita, Kansas. Paper was now available on our website at jrheum.org for viewing. Now, I'm pleased to be speaking to Dr. Kaleb Michaud, who is a senior author of the paper. And Kaleb, I want to thank you for taking the time to speak to me and our listeners of this very interesting and important article regarding how different DMARDs may have differential influences on the development of cardiovascular disease in patients with rheumatoid arthritis. So thank you.
Thank you, Earl. I'm happy to be here.
So if I can start. So if you could please summarize the important findings of the paper and also tell us a little bit about the cohort.
Certainly. Well, I first want to recognize the first author, Dr. Gulsen Ozen, who's been very busy with her residency currently. So she'd be happy to be here, but happy to be here on her behalf. This cohort used patients who are participating in Forward, the National Data Bank for Rheumatic Diseases, which was founded by Fred Wolf back in 1998. And we looked at patients who participated from 1998 through 2017, who started a variety of DMARDs and who have the rheumatology diagnosed rheumatoid arthritis. We wanted to compare the primary hard outcomes, cardiovascular disease outcomes, which was a composite of myocardial infarction, stroke, hospital heart failure, and cardiovascular disease-related death, which we linked with the U.S. National Death Index. And we took a look at those patients in those 20 years, and we, primarily found that those who took an anti-TNF biologic DMARD and abatacept, another biologic DMARD, they were associated with reduced cardiovascular event risk compared to those who took conventional synthetic DMARDs, but not any difference in comparison to methotrexate treatment. We found that methotrexate use by itself was also associated with reduced cardiovascular event risk, which you might expect to be the case from papers long ago, but are less often seen these days. And this was even more prominently done and noticed in doses of methotrexate greater than 15 milligrams a week. We also found, as others people have shown, that glucocorticoids were associated with an increased risk of cardiovascular outcomes.
Thank you. Very good. It's perfectly clear to everybody about the cohorts. And it is interesting about methotrexate, I'm sure you're aware that, it has been advocated by some cardiologists about that it may affect cardiovascular outcomes. So this, to me, was so interesting to come up with this in your trial also. Just a comment. So when I looked at the data at the individual effects of the biologic DMARDs and cardiovascular risk, it did strike me that it was only the two most commonly used DMARDs in your cohort that were statistically significantly associated with a decreased risk. Do you want to comment on the possibility? My question really comes down to power. Do you think that maybe you might have been a little bit underpowered for the other one, or do you think there's something unique potentially?
So it is true that there are more people who take TNFs than any other biologic, because that often is the first biologic that they take or are exposed to, especially since we included 1998 on, which for many years the TNF was the only biologic available. Abatacept came on a little later, at least 10 years later, and has definitely become more of a darling in the older age group in Medicare because of how that's provided. But that being said, even though the N was smaller and the other non-TNF biologics and tofacitinib, they had signs, but their confidence intervals overlapped with one. So it might be an underpower issue, but we have found other studies on this topic have very inconsistent results as well. And the question can be argued that, is it just the underpoweredness aspect of it, or is it the timing of what drugs are available when, and the exposure access as well? But it's there's a reason why some of these drugs are used more than others. When they found more success, as Dr. Freeze said many years ago, is that it's a roll of the dice of which DMARD is used, but usually it's going to be you stick with the one that works best. And if you have a better therapy here, you would likely get a better response as far as cardiovascular disease protection, as you might expect there too. So, and the other aspect is that these newer drugs often are moved to when you have not found that success early on. And therefore, there's a bit of a mix of competition between, are they doing very well in protecting them from cardiovascular disease because of the disease activity reduction, or the patients who are taking them worse off, and therefore you get the wider confidence intervals that are probably what we're seeing as the reality.
Yeah.
So, even if you had a greater N, you would probably still get a confidence interval overlapping with one.
Sure, it certainly is confounding. Because as you said, very few people, don't start with an anti-TNF. They work. We're used to them. They're on the market so long. I've been around a long time, and I'm an old guy. And if it works, don't mess with success. So
that's right. That's right.
Jim Freeze is even older than me, so I defer to him. Anyway, I found that as we were talking before that about methotrexate, that it was 18% decrease in the cardiovascular risk, which, as I read it, it actually made the difference when you added it with either anti-TNF or abatacept. It actually removes the statistical significance from it. And do you want to comment on methotrexate as we discussed it? It's like it does decrease inflammation, and that's why I said, I have read some editorials from cardiologists about the possibility of methotrexate by its anti-inflammatory effect might work in cardiovascular disease per se.
Yeah, and this is a tough one again. I mean, back, Fred Wolf and Hyun Choi's paper back in 2003 or so, when I first was getting into the field, showed the protective effect of methotrexate, primarily due to cardiovascular. And we've seen that in rheumatology again, but not so much outside of rheumatoid arthritis as the cardiologists had hoped, at least in some of their clinical trials more recently. And a lot of observational studies who've looked at this more recently haven't seen as much protection with methotrexate. And the argument would be that there's probably other drugs that are doing more to control disease activity, and they actually, when you have disease activity under greater control, you have less cardiovascular disease. And this is somewhat consistent with that. Whereas the biggest differences we see with methotrexate plus a biologic or another DMARD in comparison to others tends to be with the non-methotrexate conventional synthetic DMARDs. And that's just either goes to show the cardiovascular protective aspect of methotrexate itself, or, also to the type of patient who doesn't like or doesn't choose to be on methotrexate. And that's, we have a ton of variables here that we try to account for that, but that is sort of the uncertain aspect of observational studies is how much of it is it because they had a side effect or some other aspect that, they really like their alcohol, and therefore they're not taking methotrexate, and they're another CSD-MARD or no CSD-MARD at all, where they are not getting that added benefit. But it is of note, that, if you can take methotrexate, even if you're happy with the biologic, there does seem to be some protective aspect still with it. And methotrexate seems to be key. And also, as to quote my chief, Dr. Jim Odell, he emphasizes, as Carter Thorne and others, it's really good to get the ideal dose of methotrexate, and that we found greater protection under the higher dose levels, which you wouldn't normally see for folks who are just quick to switch to another biologic and maybe even go off of methotrexate.
Yeah, you know, to my pediatric ears, hearing this is so nice, you know, that, you know, routinely, and most of my adult colleagues too, used to go up to 25. I use I started 20 milligrams of methotrexate in, in somebody, or the equivalent dose by body surface area. I don't even mess around with a lower dose.
You're not alone, but you're still a rare breed.
No, I know. As I said, my Canadian colleagues certainly do it, you know, and I find going 25 subcutaneous is a great drug. I mean, it's a really good, anyway, I agree 100% with that, and it comes up in lots of our discussions at the journal when we get Japanese papers using 5 to 8 milligrams. Now, it might be different sensitivity to the drug, and they don't tolerate higher doses. I don't really know. But anyway, we'll move back to your paper. So it comes back really to another issue that we're sort of addressing, and that's this amazing interaction between chronic inflammation, as characterized by disease activity, we assume, and the use of glucocorticoids. So to me, when I read this, and now here's where I do differ from lots of people. I think as a lupus doc, I know this is heresy, but low-dose steroids are good to control inflammation, and when you need it, you need high dose. And everybody says intrinsically steroids are bad, and we certainly know in people without chronic inflammation, I'll agree 100% what it does to your lipids. But your lipids go out of whack when you have chronic inflammation. Anyways, it comes to the point, how do you dissect out the steroid not being good for you versus disease activity not being good for you, because we make the assumption that you're only on prednisone because you need it?
That is such an important question. So, in fact, it's that reason that I spend so much time trying to come up with what are the best disease activity measures we can have. And, you know, unfortunately, the reality is our disease activity measures are limited by what we have time to do in the clinic these days. And that's a whole different conversation and a different paper. But, you know, they will always be confounding by indication when it comes to steroid use. And Martin Boers is also sort of, you know, screaming at the rooftops. He's got some really good studies actually underway, sort of taking a look at this and some of the clinical trials in Europe going on. You know, what we did was something that not enough people have done, in my opinion, and which is using the data from Will Dixon and they're going to hate me for blanking on their last name, how to pronounce it there, but a wonderful statistician there in Canada as well, actually, years ago came up with a weighted cumulative exposure model for steroids. And they did it for infection risk, and they did it for diabetes. And we did something similar in this study where we used that way of looking at steroid exposure here. So if you're on a low dose, it would indicate, you know, relatively low exposure, even if it's chronic and recent. And it's much more loaded by what you had more recently, as opposed to, you know, 3 years ago or lifetime exposure. You know, most studies have shown like any exposure, you have an increase, but, you know, any exposure is usually because you had a flare, and that's uncontrolled disease. So, you know, we really sort of tried to go to our limits of what we had access to when it came to various ways of measuring disease activity, because we're just trying to pull that out, and we still see it, which is why so often people are trying to get to the lowest dose reasonable. And I still think that that's sort of ideal place to be. And I mean, the low dose, like you said, shows that there's some cardiovascular protection. It's just a matter of, is the low dose because disease activity isn't under control and you could be at zero, you know? Yeah.
No, I know. I love the mouse scientists because it's so much easier.
Yeah. And it's so much smaller.
Smaller, you can tell the mice you're not getting any steroid. I don't care if you die. I mean, I know that problem with human studies is that confounding by people. So anyway, this is great discussion. Anything you think we missed that you'd like to add?
I mean, I think this goes in contributing to the literature overall when it comes to what's the real world experience by folks who have this disease and take these medications. It still goes with treat the disease first, but we can't emphasize enough that so many folks with rheumatoid arthritis see their rheumatologist as their primary physician, and they may never see a cardiologist or a PCP or somebody who can actually think about what is my cardiovascular health. And so it's always something to keep into mind. So the treatments that we give, to know that if you're getting good response in disease activity, you're probably adding some added benefit, some protection here. But there's still that risk that comes with the disease. And as your editorial author pointed out, and others, that there's still this uncertainty that comes in that we have yet to figure out how best to measure that, and which is what makes me excited about continuing this kind of area of pursuit.
No, that's great. I think it's a really important step forward. I think we have to continue because cardiovascular is still a huge killer in patients with especially patients with chronic inflammation, and I think, and one of the things I really liked about this paper was they were hard outcomes. So you couldn't argue, well, what does changing your carotid IMT or your pulse rate velocity really mean?
Yep, exactly. And I will add, though, that something I've seen in my now 20 years of doing research in rheumatology is that it's been extremely frustrating to have medicines that work so well for our patients be taken away because of the cardiovascular risk in folks who are not our patients. Whether they're NSAIDs back 15, 20 years ago, to even talk of hydroxychloroquine, which is sort of our least harmful DMARD that we have, because of the cardiovascular risk that you're seeing in folks who are being used, taking it well outside of these diseases, and that we have to at least understand what those risks are and how they're still very beneficial.
No, I agree. That's an excellent way, I think, to end it. I really appreciate this, and I really want to thank you for taking the time, and I hope everybody will please read the full article, The Risk of Cardiovascular Events Associated with Disease-Modifying Antirheumatic Drugs in Rheumatoid Arthritis, and as Kaleb mentioned, there's an accompanying editorial and it's at jroom.org, and we'd love to hear your comments and questions on Twitter at jroom or by email at manuscripts@jroom.com. And thank you for joining us, and I hope you'll join again next month when I again speak to an author of a paper of particular interest that I will select for the June edition. And again, thank you, Kaleb.
Thank you, Earl. It's a pleasure.